Hello, I'm Dr. Ticiana. I'm very happy today to talk to you about the role of liquid biopsy in non-small cell lung cancer. And today I have with me a great panel to discuss this topic. We have Mrs. Lisa Briggs. We also have Umberto Malapelle and Christian Rolfo. And we're going to be having a great discussion. We're going to make it really conversational. And we're going to highlight some important points about the role of liquid biopsy in non-small cell lung cancer. Here are my disclosures and the disclosures of our faculty. And the objectives of today's talk are going to be to understand the role and the use of liquid biopsy in clinical decision-making, not only upfront with a new diagnosis of lung cancer, but also in disease monitoring and in early stage disease. And we'll talk about some future directions. We'll also talk about how the technology has evolved over time. So we'll start with a clinical case discussion. And Lisa, I'd like you to highlight your story. Thank you so much for sharing your story with us. I think it's a very powerful story and such an important one and an example for so many people. And so thank you very much for taking the time to review your story with us.
No problem. Thank you so much for having me. So I was 32 years of age and I had some symptoms, wheeze, a bit of a wheeze and shortness of breath. And I was pregnant actually with my second child. So I sought some advice from my GP, who had suggested I had pregnancy-related asthma, provided me with an inhaler. And I was using that for a period of time and never really found it made any difference actually. And then towards the end of my pregnancy, when things weren't still resolving, I was referred for a chest x-ray. And again, that showed there was nothing there, no evidence of any disease. And so I was just told to continue with my inhaler, go about my day. And, you know, once I have the baby, all of the symptoms will resolve. But that wasn't the case. So 4 months after giving birth, I actually coughed up some blood. And I ended up in the emergency department of the hospital, where they ruled out a blood clot and took another chest x-ray, which was again clear. And they sent me home with a script saying I had bronchitis. But unfortunately, the following 3 days, I continued to cough up more blood, which then resulted in me having a chest CT scan. And that did show there was something suspicious. There was what looked like a mass on my lung, but we weren't quite sure what that meant or what that was. And so I ended up back at the hospital and was admitted as a patient in hospital. And so as you can see by my CT scan here, there is the primary tumour, which is quite large, followed by the lymph node just up above that. And over to the opposite side, you'll see there was some pulmonary, like a lung collapse and some bleeding internally that was also compromising my physical state. So following the CT scan, I also had a PET scan. And as you can see by this picture, there are multiple areas based on the bright lights that are visible. There were approximately 8 locations where the cancer had spread. And so that determined the stage of my diagnosis. I also had a bronchoscopy, which I was under general anesthesia for. And that so with the bronchoscopy, that was able to detect that I had lung cancer, but unfortunately the tissue was insufficient for use at the time. So I wasn't able to determine whether there were any additional markers or drivers. We didn't know what was, causing the cancer to do what it was doing. So we knew it was lung cancer, but that was about it. It was very limited information. And that's where I had to undergo a second procedure. And that was a repeat biopsy that I needed to have. It took about 6 weeks until I was able to get onto a clinical trial. And that's when I started my first treatment as a result of an ALK mutation that was eventually identified. But it did take 2 biopsies before we were able to determine that I was ALK positive.
Thank you, Lisa, for that review of your story. So we'll talk a little bit about initial diagnosis, and I'll have Umberto, please give us your take on initial diagnosis of lung cancer and what do we need to do?
Thank you, Ticiana. And as you can see in this slide, in the left part, we have the tissue samples. And we need these type of samples to start with the diagnosis, because we need to analyze the quantity and quality of cells. We need to define the shape of these cells to verify if there is a cancer in first instance, and then to define what type of cancer is. And the tissue, the left part of this slide, is represented by different type of biological materials. And we need of these type of materials to make possible the diagnosis. After to this, we can proceed with other type of samples that you can see in the right part of this slide, like as liquid biopsy or other type of biological fluids that we can use to analyze the mutation carried by DNA or cell-free DNA from the patients, as discussed by Lisa before.
So let's talk about the use of liquid biopsy at diagnosis. I think, Lisa and Umberto have explained to us the importance of, number one, getting the diagnosis of lung cancer, but also importantly, to really hone in on what kind of lung cancer, the subtype of lung cancer, looking at the genetic mutations in the lung cancer that drive the lung cancer and that help us identify the best treatment. So it's very important to do this kind of testing at the time of initial diagnosis. And there are different ways of doing this. We talked about doing a tissue biopsy. And like Lisa, many patients have to undergo more than one procedure if there is insufficient tissue to do the initial diagnosis for molecular testing. So you can do the testing in tissue versus liquid. And what are the potential, advantages of one versus the other? Umberto, can you give us your take on the pros and cons,
Sure.
Liquid versus tissue, and are they complementary? Can we do them both at the same time, or should we do them in sequence?
This is a really important point, Ticiana. As we can see in this slide, we can have some differences. By using tissue biopsies, we can make the diagnosis as we have discussed, but in some cases, due to the low amount of material that we have the possibility to proceed with molecular testing. In this case, we don't have this problem if we proceed, in example, with a liquid biopsy first approach, because in this case, we have enough quantity of material to proceed with the molecular evaluation. But in this case, we don't have the possibility to analyze the shape of the cells because we analyze nucleic acids and not the cells. But on the overall, we can consider the information that we can retrieve from tissue or from liquid biopsy as integrative information, because we don't have an exclusive information, but we can collect different information from these two different biospecimens, and this can help us and the patients to stratify the better treatment options at diagnosis. And then we can reuse this during the follow-up to evaluate the behavior of the patients under a specific type of treatment.
So this study here that is mentioned, the Nile study, was actually a very interesting study that looked at patients who were going to have tissue done for molecular testing with a new diagnosis of lung cancer. And so what they did was they also looked at adding the ability to do liquid biopsy for these patients. And this was a study with over 200 patients. And what it showed was that for patients that had standard of care tissue testing and also had the liquid biopsy done, it was actually pretty helpful. And it helped identify more of these mutations that we can target. And it was also done faster. So one of the things about liquid biopsy that is pretty clear is that it has a quicker turnaround time, so you can get the results faster. And if you identify the result that is a mutation that you have a treatment for, you can actually start treatment quicker. And in this study, it also showed that if you identified the mutation in the blood, not only could you act on it, but it actually led to people getting onto the right treatment as well. So this was an important study. I want to stop here and ask Lisa, your take on liquid biopsy from a patient perspective and its importance in initial diagnosis.
Yeah, look, just building on from what you were saying, it's also really important to patients that when they arrive at their first consultation with their oncologist, that they actually have the information to have informed discussions with patients about what the next steps might look like. So actually that quicker turnaround time can make a huge difference, because often you might see your oncologist and they still don't have any results from tissue. So sometimes it's not just about the initiation of treatment, but it's about the step before that, and being able to have those really informed discussions with the oncologist about how you will proceed. But turnaround time is huge. I mean, obviously in my case, I was actually in a very physically vulnerable state. And for me, we knew I had lung cancer. We just didn't know what was driving it. And that could have really filled a gap as, to save time, to save on I suppose that additional physical trauma I had to be exposed to with an additional tissue biopsy procedure. And I think we need to also remember that when patients are diagnosed with lung cancer, it's a really stressful time. Often you've got a lot of emotions you're processing, and mentally and emotionally, you've got so much going on. If you could have a test that could help alleviate a lot of the pressure and stress, and to know that this test allows you to drive the decision-making process forwards, and that you can then access a treatment that will help improve your outcomes, then I think, it's really what anyone would want, right? So.
True. Okay, so let's talk about the test itself and some of the techniques that are used to diagnose these targetable mutations. Umberto, can you take us through this slide?
Sure. In this slide, you can see the different techniques that we have to analyze this type of mutation, but we need to take into account that not all this technique can be used on liquid biopsy, because we need to have an adequate sensitivity to found a low quantity of mutation in blood. And as you can see, in this case, it's preferable to use digital techniques, like as digital PCR or next generation sequencing. We can find also the specification of this term in the glossary of this presentation, but it's really important to take into account that only by using next generation sequencing, we are able to find in the same time different mutations by using one assay. And it's really important to have an harmonization of different results that we can obtain by using different of these platforms, because only in this way we are able to recognize if the mutation that we have detected is a real alteration, depends on the tumor, and is not an artifact or another type of biological events that we can find in blood.
So Christian, why don't you take us through this slide? You and many others have led this amazing effort of updating sort of the role of liquid biopsy with the International Association on the Study of Lung Cancer.
Thanks, Ticiana. Yes, this is on a publication that we just launched with the intention to make aware what is the real use of liquid biopsy in situations like, for example, Lisa, and thanks, Lisa, for sharing your case. We have, for example, here 3 scenarios. One is the sequential approach, and that is when we have tissue enough, and then we want to have liquid as a second option for that. The second one, that is the old approach that we was using before, and I will explain why it's important to have the second one, that is the complementary approach, liquid and tissue biopsy at the same time. The advantage to have both technologies at the same time is because we are able to have a complete picture what is happening in the molecular part, so the characteristics of the tumor in terms of aberrations, alterations that we can target with medicine. Because nowadays we are not only focusing one single alteration or a single mutation, but also what happened in the other mutations. I always explain to my patients, like this is on a bus that you have a driver, you have also some co-drivers, some secondary drivers, and you can have a passengers that are behind, that these passengers can be troublemakers. This passenger could impact in the driver conduction, and that is happening nowadays. So we know, for example, in patients like Lisa with a ALK translocation that we have, for example, other commutations, like for example, TP53 is another aberration that could impact negatively in the time to response, not in the response, but in the time of this duration of response. And the last approach is the plasma first approach, is like this was the case of Lisa, for example, when the tissue is not sufficient enough, the possibility to have the liquid biopsy to diagnose the aberration or detect the aberration. And that is in the first step, then we will talk about the resistance.
So Christian, let me ask you a question though. Let's say somebody does have a biopsy, they have insufficient tissue, can't do the genetic testing. You end up doing the plasma or the liquid biopsy, but you don't get any actionable mutation on the liquid biopsy. What next? Do you trust that result, or do you have to go back and do additional testing?
That's a very important concept, because we have a percentage of patients that are not shedders. So the patients that cannot have in the blood the quantity of DNA that we want to detect the mutations. And that is, in some cases, is not depending on the tumor burden, so the quantity of disease that could be spread. That was a problem before with the technologies that Umberto was mentioning, was in some of these technologies that the possibility to catch at the sensitivity was very inadequate, we will say. We was not able to capture these patients. But nowadays we are able to capture more patients, but still we have a group of patients that are not shedders, and that is a problem. So for these patients, we need to repeat the biopsy and see what happened, because I know that this is a tricky situation for patients. They need to go under 2 biopsy differences, but that is important also that we make aware also the oncologists and the pulmonologists, interventional radiologists, that the quantity of tissue need to be adequate from the very beginning in these cases. We are not using any more cytologies, even though we have some technologies that we can make the cytology useful, but for having a complete picture of what's called next generation sequencing that Umberto mentioned, that is a number of genes, we need to have a good tissue obtention.
I think as well, just from a patient perspective, I look at it and say, if you don't look, you don't know. So even though you may do a liquid biopsy and it may not show any actionable drivers, you've still at least given it a chance to find something. And sometimes it does open up multiple opportunities that you wouldn't have otherwise found. So, and that's really important even when you're looking at types of treatment. I mean, it could be the difference between accessing a treatment that gives you a really good quality of life versus a treatment that perhaps doesn't give you such a good quality of life and, you know, comes with a lot of symptom burden as a result of that. So, yeah, I think that wherever you can get the information is really powerful for a patient, and it gives so much more reassurance.
Yeah, and coming back, that's a very good point. And also coming back to the complementary approach, what we want to do both together is because also in some cases, in some patients, the tumors are very heterogeneous. So in some patients, we can have differences between the primary tumor in the lung and a difference in clones. We call clones the different kind of cells involved in the tumor that are, for example, in the liver or in other sites of metastasis. So liquid biopsy is able to capture these differences between the tumors because are all of them traveling in the blood, and we are able to fish that in some way.
And so this is a trial that I'll review with you that basically enrolled patients who had a diagnosis of lung cancer. They didn't have prior treatment yet, and they had their blood sent for liquid biopsy. And I'll focus on the ALK group of patients just for our discussion. So these patients had their blood sent for liquid biopsy. If the ALK rearrangement or translocation was identified in the blood, they then would receive alectinib, which is a type of targeted therapy that is approved for ALK non-small cell lung cancer. And what they showed here was that when somebody had in their blood the ALK rearrangement identified with liquid biopsy and they received the alectinib, they had good treatment results. And so I won't review all these numbers with you, but what it basically showed is that in this study, identifying the ALK in the liquid biopsy allowed patients to get the right targeted therapy, and that the results were very similar to the results that we saw in the studies that were done that led to the approval of alectinib using the tumor tissue to diagnose ALK. So again, showing that liquid biopsy can really be a way to identify rare mutations and get patients on the right treatment. So Lisa, I'll get this back to you. Tell us a little bit about how testing was done and how things went with you after that.
So once I knew that I had the ALK positive mutation, I commenced a clinical trial, which I was on for 3 years. And then unfortunately, I became resistant to that type of treatment and ended up having the cancer spread to my brain. And there were 6 locations in which that spread to. And at the time, I didn't have access to a liquid biopsy test and was required to change to another targeted therapy without really knowing whether or not it would even work. So we just had to make a decision because obviously accessing the tissue was not really an option. And so, yeah, I changed to a different treatment and was on that and have been on that up until today. So that's roughly, it's nearly 4 years now.
Okay, well, thank you for sharing that with us.
Yes, fantastic, Lisa. That's a really.
I mean, I should probably also say that I did actually enroll in a clinical trial that looked at liquid biopsies, and it was a US-based trial. In fact, no, it wasn't. It was a global trial, but I had my blood drawn in my local hospital, and unfortunately, it got rejected by customs, so never made it to the trial site. And it wasn't until my family and I decided to take a holiday over to the US, and we had a phlebotomist sent to my hotel room, interestingly enough, and my blood was drawn and it was sent to the trial. And that was looking at patients under the age of 40 to try and determine what was driving their lung cancer. And that was through Go-To Foundation for Lung Cancer at the time. So those results have been published, and yeah, it just shows the power of liquid biopsies in detecting these types of drivers, and then obviously the benefit that they can make in terms of treatment decision making.
Right.
Sorry, Ticiana, no, she was pointing at something that is really interesting.
Yeah.
That the difficulty that patients have, or the barriers that patients have to access to the technology, even on a simple custom problem, can make that the patient is not able to access to this information or even to see mechanisms of resistance. So I think we need to make some thinking together with authorities and advocacy groups and all together to try to make this accessible to everyone around the world. It's a big problem, I would say. Sorry, Ticiana, for interrupting.
Oh, that's okay. I think that's a great point. And we'll talk a little bit about that down the line. But this brings us to our next topic of discussion, which is there a role for liquid biopsy in disease monitoring? And what about in the setting of somebody who's already on their targeted therapy? Now there's evidence of progression of the cancer and patients need to switch to a new treatment. Can liquid biopsy help in looking at mechanisms of resistance to try to better tailor the next targeted therapy option for them? What about for future directions? Can we use that for immunotherapy selection? Can we use that in early detection of disease after curative surgery to try to help determine who needs post-operative or treatment after their surgery to reduce the risk of recurrence and improve cure rates? And can we now couple some of these tests for patients who are undergoing lung cancer screening and really look at drawing blood and coupling that with low-dose CT scans used for lung cancer screening in patients with high risk of developing lung cancer? So we'll talk about this over the next few slides. Lisa, you explained to us how you had follow-up imaging and it also showed that things were changing for you. So tell us about your scans and kind of what happened from there with your new treatment. It sounds like things went really well, but it was a tough time.
It was a really tough time, and there are so many emotions that you're experiencing when you get told that, you know, your cancer has progressed, and especially when it goes to an area such as the brain, which is so sensitive. I have a young family, and the impact on them was something that was really playing a lot heavily on my emotions and my mind. But interestingly enough, I had these 6 lesions that you can see on the screen without any symptoms. So this was a scan that I had been proactive in asking for, and had several prior. And this was the first one that showed multiple lesions. However, as I said, we tried a treatment not knowing whether it would work. I thought it was a really big risk, and so I actually had some radiation therapy pre-planned as a backup in case. And even having to coordinate all of that at a time when you've just been told that, you know, your cancer's coming back, it's returned, and it's not just returned, but now it's in your brain, which can affect so many of your physical symptoms, physical and mental processing. And so I was lucky that it did work. We had a scan within 6 weeks, and the lesions had all disappeared, they had resolved. But I knew that that was just a temporary thing, and that eventually, you know, the same thing may happen, which it has. And I did find there was recurrence in my brain recently. And I haven't changed the targeted therapy, but I did end up with radiation to those spots, or to that spot, I should say. But again, I haven't had access to a liquid biopsy to determine what was actually driving that. What were the changes that were occurring to my cancer that were causing this cancer to grow in my brain? And so that we will never know.
Okay. So those are important points that you bring up. I'll let Christian talk a little bit about the role of liquid biopsy for disease resistance. And Christian, if you could also talk about, you talked about the patients who have disease where you use the term shedders, where they have more or less circulating tumor DNA that impacts the ability to find it or not. And I think in patients with ALK, you know, having the brain recurrence or the brain progression, unfortunately, is not uncommon. But what is the role of liquid biopsy there in patients who have brain-only recurrence? Is that doable to identify changes in the blood?
Yeah, so starting from the resistant mechanism, obviously liquid biopsy, the first use that we have in these patients was that diagnosis and recurrence, and we was not doing nothing in between. So nowadays we are using a lot to monitoring, because we have some tools. We can say, for example, see if the DNA is decreasing or increasing during the treatment. We can have an idea what will happen in these patients in a long term in recurrence or not. When we went only for the recurrence, it's important to know that some of the common biomarkers like EGFR, ALK, and others, we know exactly the percentage, more or less, of the mechanisms that are involved in the resistance. But even though there are some patients that are not falling in this category, so we have patients that we will never identify a mechanism of resistance. We have actually in some of these scenarios, in the case of ALK, also some drugs that are acting without knowing the mechanism of resistance, or even back into chemotherapy in some patients is also an option. In the case of the brain, that is, we know that unfortunately several of the patients with lung cancer have this possibility to have brain metastasis. Liquid biopsy, as intended in the blood, is difficult that we are catching when the disease is only in the brain, the quantity sufficient of DNA that is in the blood to characterize the mechanism of resistance. What we are using now is, for example, and is there, the test in other samples like CSF, and this is not still obviously approved, it's not a large scale use, but there are some centers that are using that, and there are recent publications in the literature that support the use of CSF, that is the liquor that is coming from the brain, that we are taking from a lumbar puncture and analyzing. The good thing of the CSF is that it's very pure compared with the blood, and that what means that the quality of the DNA that we will get from there is very nice and very easy to characterize, and we will get some mechanism of resistance from there. So it's important that we test, obviously, all the patients, not only during the diagnosis, but Lisa said, for example, at the moment of the recurrence, because we can completely tailor or customize the treatment of these patients according to these progressions.
So Lisa, we talked a little bit about you participating in a clinical trial. We mentioned here the spacewalk study. This is a study that you have some knowledge about that has involved patients with ALK non-small cell lung cancer. Give us your take on the spacewalk study and your perspective on being involved in clinical trials.
I mean, I think it was an amazing opportunity because this was like one of the first opportunities for patients with ALK-positive lung cancer to obtain a liquid biopsy to identify what was actually driving their resistance to the treatment. So what it did do was it allowed patients who had progressed to obtain the most appropriate treatment based on what was happening at the cancer level. So having that liquid biopsy could identify the mechanism of resistance, and then the oncologist and treating team were able to then make appropriate treatment decisions. But what was also interesting was the remote consent process, which meant that it didn't matter where you lived or where you were. It was a US-based study. So in the US, you were then able to consent without having to actually travel to the location and spend all that time and energy and effort to go through the process. Because clinical trials can have, at times, be like a little bit burdensome on participants. And so the less that you can create for a particular patient, where you're just offloading, their capacity to have to organize, care for their children so that they can then attend a center just to sign consent. And, it makes it so much more convenient. But clinical trials, from my perspective, are amazing. They open up opportunities for patients like never before. It's, real world opportunities to actually make a difference, not just to the science, but to the outcomes. We've seen such amazing trials that have been developed that are now incorporating blood and able to detect things that you wouldn't be able to access if you weren't on a trial. And I think that goes back to Christian's point earlier, where he was saying that, we need to make this technology available and easily accessible all around the world. And that's one of the challenges we face, is that unless you have access to a clinical trial or you have access to a local lab that's performing these tests, or you have enough money to afford, a commercial platform, examination of your blood, then really access is very limited at the moment. And, this was a study that basically allowed access to patients, and it allowed them to have, better treatment decision-making options.
Yeah, great point. So let's talk about the liquid biopsy to monitor disease progression. Christian, take us through this slide.
Yeah, this is a case of one of the patients that I saw in consultation as well. And as you can see here, this is the iconographic representation what the liquid biopsy results are, and the different colors represent different alterations that this patient have. In the part below, you have the disease of this patient in the CT scan. In the superior part of the images is the lung, the lower one is the liver metastasis. And what happened with this patient, she had was a very young patient as well, like Lisa. She had another kind of alteration that is an EGFR mutation. And the histology, so the kind of tumor that she had was a mixed tumor. So it was a very complicated from the very beginning situation. in the beginning, she had a mutation with EGFR, and as you can see in the superior part of the graphic, you have there a number that say 9.8%. These numbers means the percentage of DNA that was in the sample. And as you can see, the second one that says 0.3 was a decrease due to the treatment when we start osimertinib. That is another kind of medication, oral medication that we have for lung cancer. Unfortunately, this patient, as you see, is growing. These lines and colors are growing, and new colors are starting there. So these new colors represent the mechanism of resistance. And she has a typical mutation that is a mechanism of resistance that unfortunately we don't have a lot of treatment to give for this. And she went under chemotherapy, and you see when she received chemotherapy, she had a decrease again of these colors, and the graphic is more affusolate, we will say, in terms of the shape. No? So that means the capacity that we have to tailor the treatment according to the results of the liquid biopsies.
Umberto, any other thoughts on this? Is this something that is ready for prime time, or is this something that needs to be incorporated in clinical trials?
I think that this is an option for the clinical trials in this moment, because we need to verify some technical aspects before to transfer this in clinical practice. Only for this, because from biological point of view, this is a really nice, really impressive option, because as you can see in the right part of this slide, we have also the possibility to monitoring the quality of different mutations in the same gene and different genes in the same time. And then we can compare and collect this information with the quantity of the percentage of cell-free DNA, as discussed by Christian, to use this not only as a static tool, but as a dynamic one. But we need to standardize this type of procedure, not only from the analytical point of view, not only from the technical point of view, but also from the pre-analytical point of view, the way that we use to collect the bloods, the way that we use to collect the other body fluids, because we need to standardize these around the world, and then we can transfer these in clinical practice.
I will disagree kindly with my friend because recently we have, for example, some of the companies have approved the second time point immediately. So in some states of the United States here, we have the possibility to do at the diagnosis of 6 weeks after the treatment in patients with targeted alterations, the liquid biopsy to see this decrease and to analyze what happened. So we are using this in clinical practice, actually. It's something that maybe in other countries is not applicable, but we are using, and several of our patients are have benefit for this tailoring or customizing treatment approach.
Sure.
So Christian, could I? Oh, sorry, Umberto, I'll let you go first.
Sorry, Lisa. No, this is really nice, because this is the point of view of a physician working in USA and another working in Europe, no? Because this is a real option in USA, but today is not a real option in Europe, because in Europe, the only 2 approbation that we have for liquid biopsy is at the beginning when we don't have tissue, and that the resistance disease only to evaluate the presence of T17M mutation in EGFR.
Absolutely.
But this is the really nice point, because it's the different view from different physicians that works in different countries.
Absolutely. That's the problem, that unfortunately technology is available not in the same way and the application the same way in all around the world, in all the countries. So Lisa, you was asking something.
Yeah, I'd love it if you would be able to share some of your experiences of how you would communicate to the patient about this process, and at what point do you have the conversation to talk about the fact that things are starting to change, and sort of some of the, I suppose, experiences you've had in terms of how the patients handled it, and what are those conversations that you do have?
No, that's a very good point. So I think it's here, when we are talking about education in liquid biopsy, we need also to educate patients, because sometimes we make several decisions and we take decisions and the patients are part of them, but we are not really sure if the patients are understanding all the message. So we have also a very good luck that our nurse and nurse practitioners are training for this liquid biopsy process, and it's a good opportunity to explain patients more in details. The conversations that we have is important to have this liquid biopsy monitoring in patients, and in some patients, obviously, we don't have NCC guidelines, we don't have guidelines for all these situations. So we are doing that in a very personal way. So we have patients that are progressing, like you say before, you have a progression in the brain, but you was not changing the treatment, because with some, for example, local treatment, you are able to control the rest of the disease. So it's something that is patient by patient. If you have, for example, in this patient, a mutation that we don't have any mechanism to cover this mechanism of resistance, any opportunity, because there are no drugs. There are some drugs in clinical trials, but we don't have all the patients the opportunity to be in clinical trials. So it's important also that we discuss decisions, and in some cases we need to switch the treatment in time before this became very difficult to treat.
Yeah, because it is a really fine line and balancing situation there. I mean, if the cancer was to spread to the brain, then, you know, that would make perfect sense that you would change treatment early, but you're not to know that until you see it on radiological progression and on a scan. So in the same time, if you do change too early, then, you know, before you've seen the evidence on a scan, then potentially you're ruling out options like local type treatments, you know, your surgery, radiation treatment that patients may want to access. So I think it's a really interesting conversation, and I'd love to see, you know, the research progress in this space, because I think patients want to know when things are changing, but at what time point is, I suppose, the question, and how does that then change the trajectory of their treatment approach?
And that concept we are using also in some other directions, like, for example, patients who have resected disease, and we want to also tailor treatment. So there are some, that is completely research, but it's something that we are going in that direction.
Yeah.
So let's talk about future directions, because I think this is the perfect time to talk about some of the points that we've already brought up, is access to testing in different parts of the world. I think we have our panel here, you know, from different parts of the world, and this was actually on purpose, because I think this is very important to discuss. And so I'll let you take it from there, Lisa. You were talking about access to testing. Tell us your view on that and what you've encountered.
So I come from Australia, and here, I mean, we have such amazing technology available, and we do have liquid biopsies available if you partake in a clinical trial. There's an amazing study in lung cancer at the moment that is for newly diagnosed patients, and they're collecting both tissue and blood where possible. And that's going to help direct treatment options. So that's a new and exciting area here. But unfortunately, our regulatory and reimbursement system doesn't acknowledge the liquid biopsy test. So if you want to access treatment, such as a targeted therapy, any treatment actually, you need to have a confirmed tissue diagnosis. And although there was a situation where, say in EGFR lung cancer, there was a series of blood being collected in labs that were able to detect the T790M mutation. And when it was available on compassionate access, the pharmaceutical company was providing that treatment option to patients. So it didn't matter where they progressed. The trouble is, if you have a particular patient that has progressed in the brain and another patient that's progressed, say, in the liver, the access of the liver tissue is a lot easier than the brain. So now that compassionate access has stopped, and these particular EGFR patients, you know, it basically comes down to luck. Where is their cancer going to progress to? If it's in the liver, great, they can access the biopsy, but if it's in the brain, they can't. And that now means they can't access the treatment via our regulatory and reimbursement system. And that's where it's creating what I would say is a bit of an inequity of who can and can't access the treatment in our own country. So currently in Australia, the only way you can access liquid biopsies is either through a clinical trial, through a local lab, or if you pay the money to access it via a commercial platform. But even then, if that treatment is listed on our regulatory system, that you can't access it anyway. So it's really clinical trials that are driving the way for treatment direction and access of treatment via liquid biopsies now.
This is related with the point that we have discussed before, no? That we don't have the same type of access around the world, because in example, also if we take into account that in USA, we have a companion biomarkers approach for this type of assay, you know, as Christian discussed before, we have 2 different assays that we can use in USA for liquid biopsy, one in non-small cell lung cancer and another one in different type of solid tumors. But in Europe, we don't have this type of approach from a regulatory point of view, because we have a biomarkers companion, not a companion diagnostics. And in this case, we can have different platforms that we can use for different assay, for liquid biopsy, for tissue. And now we need to harmonize this procedure, because as we have discussed before, for USA, we have 2 externalized approach. But in Europe, it's possible to make this type of analysis in home. And we need to use some standardized protocol that can give to the patients the possibility to have the same results in different lab in different times. This is important because we have different regulation in different parts of the world.
And actually, in some areas of the world, they don't have access at all at liquid biopsy, not even in the diagnosis. So this is very complex and making plans to apply. So I think liquid biopsy in clinical trials is a good option, but we need to think in the plan B in other situations, because not all the patients will make it to enter in a clinical trial. So that's a problem.
What about the harmonization of the testing platforms? We talked about different ways and different tests. Is there one way to test it? What are the efforts to make this a reliable and sort of across the board standard test for liquid biopsies? What are the efforts?
Yeah, there are several efforts on harmonization, especially also about the pre-analytical conditions. So Umberto and me, we are working in the International Society of Liquid Biopsy, that our aim also is to create awareness and standardizations of the process. We are part of as a society, we are part of the International Alliance for Liquid Biopsy. So this is we call ILSA, that is an initiative from the NIH. And there are different stakeholders there, from Japan to United States, present from Europe, that they are working, including, for example, a good one that is blood pack, that they are working a lot in preclinical, pre-analytical conditions that are very important when we are using in-house technology. So there are several efforts, and they are behind the scene trying to make this possible for patients, and also several advocacy groups as well. In ILCN, we have also an advocacy group. We have also the honor to have Lisa with us working in some initiatives. So it's a very important common effort to everyone. Yeah,
and I think as well, like, patients don't know a lot about this area, and when they go to get a test, you know, I hear it all the time, people saying, I say, well, what did you get tested for? Oh, I got tested for everything. So they don't understand there are different panels, there are different platforms, you know, and I think it's really important that that information is communicated to the community, because some people are paying a lot of money to get these tests performed and not actually knowing what results they're even going to obtain from that, and how then that's going to change their treatment or their care. And you know, it's disappointing when a person comes back and they say, oh, it didn't really show anything. And you don't know whether that's either the interpretation of the results, because that's another thing with, you know, you can get lots of information. And sometimes, you know, I've heard clinicians say there is so much information that you actually don't know what to do with it sometimes. And it can not necessarily help create that benefit for the patient. So I think it's important that there is education provided for everyone, but most importantly, for the people who need the test and who are going to be asking for the test, to actually know what they're going to be getting when they go ahead and get it, and how that might change their care.
And this is a very important point, because sometimes when you are discussing with colleagues or even with patients, they say, no, but the patient already have the liquid biopsy done. And when you go to analyze, it's only a single determination. Or so we are not talking about mechanism of resistance. We are not talking about mutation. So it's important as a physicians, as a healthcare system, and also as a patient, that we are really informed what we are using and the limitation of the technology that we are using.
And also the type of NGS, because NGS is not in a single assay. We can have an NGS with 5 genes, or we can have an NGS with the entire genome. It's really different. It's really different, not only in analytical terms, but also in type of results that we can have, and interpretation, as you have discussed, Lisa, of this type of results. Because if we use a wider approach, we can detect more mutation, but we need to analyze the clinical value of all the mutations that we have detected, because we have different clinical values for different mutations. We now have not only real-time PCR or a single gene determination, but also in the world of next generation sequencing, we have different sides of the panel that we can use.
And it's important to know when is the right timing to perform those particular tests, where you want more information versus less information. And I think that's a really great area for many people at the moment, where they aren't sure. And you're spot on, Umberto. You know, I hear patients say all the time, I'm getting next generation sequencing. So they think they're being tested for everything, but yet it might only be looking at the driver mutation. And similarly in the EGFR space, I mean, maybe correct me if I'm wrong, I'm not sure, but my understanding is that if you're looking for the T790M mutation, you also need to be checking that you also have still the EGFR driver mutation, because if you don't have that, then you're not going to find the T790M on resistance, and maybe they have transformed into, say, something like small cell lung cancer or another driver. Is that correct, or am I?
This is another important point, Lisa, because this point highlights the importance to integrate the information between liquid biopsy and tissue, no? Because by using the red biopsy, the red tissue biopsy, we have the ability to define if there is a switch from the first morphological part of the tumors respect to another one. But we now have the possibility to verify the heterogeneity of the distribution of the mutation in this tissue. But combining the information of liquid biopsy, we can analyze this on another level. No, we can combine this source of informations.
Yeah, there are patients who can have T790M without the EGFR as a mechanism of resistance. There are patients who are losing the EGFR as a part of a mechanism of resistance. So it's very variable. It's not, there is not a canonical answer for all the patients.
Sure. And in this point, I think that the rule of molecular tumor board or multidisciplinary team is really important, because you need to share the experience with the oncologist, molecular pathologist, and radiologist to verify all the information that you can retrieve from this type of analysis. So, because are all different point of view that see the same thing, no?
Exactly.
Okay, well, that's a great discussion. Umberto, any other closing thoughts here as we wrap our discussion up about the future of liquid biopsy?
This is the future of liquid biopsy. This is a paper that we write with Christian and all the team of International Society of Liquid Biopsy, in which you can see the possibility to transfer all the knowledge that we have acquired in metastatic setting in different settings, like as screening or cancer interception. The possibility to use liquid biopsy in a wide range of population, in which we are able to identify one specific alteration or different specific alteration related to the possibility to have a cancer in future.
And the last thought that I have, Ticiana, and this is very important, if you are a patient and you are going to a doctor, you need to try to make the possibility that you have to be tested, because this is in 2021, We need to test our patients from upfront for every treatment in lung cancer, in advanced lung cancer, obviously, because this is the way that you can completely change your life and completely change the course of the disease, like was the example, the history of Lisa today.
Lisa, your thoughts?
Yeah, I mean, liquid biopsy is such a powerful test and it's used across the spectrum of care. However, I think it's time that we start to look at what steps that we can all create by working together, including consumers and advocates around the world, so that we can drive the implementation into the clinical setting. Because as you can see from my case, I've had minimal interaction with liquid biopsy. I had to fly across, the other side of the world to access the test. And it was the simple procedure of putting out my arm, having the test and going about my day. And so the benefits are endless, not just from the actual practical side, but from also the emotional and mental side, because you're managing, it's more than just yourself when you've got cancer. I have a family and loved ones as well. So my point being that we all need to band together to try and look at the next steps for a path towards implementation, because that's where it's going to have the most impact at the people that are using it, not just the science, but at the bench. It's for the people. And if we don't start moving this forward so that people have access, then it really is just another tool that is a scientific discovery, and that's all.
Awesome. This has been an amazing discussion. I want to thank all of you for being here with us today for this discussion about liquid biopsy and its role. And I think, Lisa, thank you so much once again for sharing your story, for giving your patient perspective. It just makes it all the more important why we do this and how we're doing it. And I think your points about everyone working together is the way to move it forward for sure. Thank you, Umberto and Christian. We also have some additional educational resources that I'd like to point out that will be available. There's a glossary of terms, and we also have patient resources from the GoTo Foundation for Lung Cancer. We have several articles that if you want to read more about some of the things that we discussed today, please go to the site and you can have access for further reading. Thank you, everyone, for joining us today.